for inviting me for this very inviting talk. Hopefully, I make justice for the topic given to me. Feels like another exam for me. I'll directly jump to the case. I'm not sure how many of you have read this case. I'll go through the details just for the people who have not gone through. This was proposed to me some time back, about a month back. The organizers had provided the details of the case. This is a 42-year-old gentleman who was apparently normal till 3 years back, developed sudden onset of tiredness, loss of weight and polydipsia. This was after an episode of COVID-19. He lost 4 kgs. He went himself and tested, was found to have high sugars. As usual, he went on to consult an Ayurvedic doctor and started medicine. 1 month later, he noticed to have frothing in the urine and consulted a nephrologist. By the time already his creatinine was 5, had significant proteinuria, albumin was 4.7 and ultrasound showed bilateral small kidneys. Essentially a chronic kidney disease with proteinuria and renal failure already in an advanced stage. He was started on conservative management and diabetic management, details of which were not available. The crux of this would be a 42-year-old gentleman with diabetes, proteinuria, small size kidneys, GFR would be around 14 ml with proteinuria of 3.1 grams and a serum albumin almost near normal or more than normal. So at this juncture, before going on to the next discussion, what are the possibilities? Probably post-COVID diabetes mellitus, all of us have seen in our practice, COVID tipping the balance. Is it a CKD, U or chronic interstitial disease because of bilateral small kidneys and he was not very severely hypoalbuminemic? Is it a glomerular disease, something like an FSGS, IgA, MGN, what we see normally, coming with the severe renal failure to us, already presenting with the severe renal failure? Is it diabetic nephropathy? All of us see in our practice somebody presenting with diabetes, proteinuria, diabetic nephropathy, we do see in our practice. And any drugs, because he had significant history of Ayurvedic medicine in his clinical presentation. So looking at it, probably a chronic interstitial disease, probably possible, a glomerular disease, diabetic nephropathy difficult to counter, but probably less likely because the onset has been very short. Drugs, definitely yes. We cannot tell no, any drug causing especially Ayurvedic medication. So after 2 weeks, his creatinine jumped to 10, it was 5. He was advised to start on dialysis. As usual, he went away, took some Ayurvedic medication, came back with a creatinine of 15, had a lot of uremic symptoms. He received 3 units of Paxil. His diabetic medications were stopped and his sugars were normal. He went on regular dialysis. His blood pressure continued to be normal on dialysis and he was needing antihypertensive medication only after 1 year of initiation of dialysis. He was on twice a week dialysis. His dry weight was 39 kgs and interdialytic weights were only 3. Outputs were very minimal. So to note here, he had severe anemia on dialysis. He was almost more than a year on dialysis. His weight was only 39 kgs. He had no significant past history of any kidney stone disease, UTI. There was no family history, no evidence of any infections like tuberculosis. He did not have any evidence of diabetic retinopathy or any other macro or microvascular complications. His cardiac evaluation was almost normal except for an LVH. At this juncture, probably chronic kidney disease, chronic interstitial nephritis probably, or is it a CKD-U? It could definitely be a chronic glomerular disease, FSGS. We commonly see people coming with severe renal failure, going on dialysis. Diabetic nephropathy, highly unlikely because there is no retinopathy, very short duration of diabetes, small size kidneys. Drugs causing renal failure, yes, definitely possible. What are the unusual pointers here or probably missing info which we didn't get? Diabetes and renal failure detected at the same time, bilateral small kidneys, hypertension came in after 1 year after the onset of dialysis, severe anemia needing blood transfusion in the initial part. He continued to be underweight and as I mentioned, there was no retinopathy, had a significant history of alternative medication, not biopsied, hence we don't know what was the native kidney disease. Possibilities I have already discussed, probably CKD, CIN, glomerular disease, diabetic nephropathy unlikely. Should we keep in mind any unusual disease like myeloma-like disease, amyloid or IgG4? Possible because he received a lot of blood, underweight. Drugs causing renal failure, still possible, but probably it would have worsened rather than leading to renal failure. Going forward with the case, his pre-transplant evaluation was as usual, everything was good, hemoglobin was good, small size kidneys, there was no liver or spleen problems, calcium, phosphorus were okay, PTH was the usual for his CKD, and since he didn't pass much urine, we didn't know the proteinuria, PCR was not done, had 2+ protein, cultures were negative, his stress MPI showed mildly relatively increased uptake in the septum of LV myocardium, probably septal hypertrophy. They opined probably due to systemic hypertension. Otherwise, nothing much to write home about this. LV was 45 to 50%. So, native kidney disease, probably I would feel a non-proliferative glomerular disease, something like an FSGS. Most likely, CAN added with the insult of COVID. Is it a non-diabetic renal disease like non-amyloid like illness? And a rare possibility of diabetic kidney disease, which already I said unlikely. He was worked up for a transplant, wife as a potential donor, immunological workup was negative. He received ATG as an induction and was maintained on tacrolimus, MMF and steroid. He did well, his creatinine was 0.97. His sugar came back, so he was started on hypoglycemic agents. Post-transplant period was uneventful. He had persistent hypomagnesemia needing magnesium supplements. He was on regular follow-up, did well for 3 months. He gained weight marginally from 39 to 43 at 3 months. He received standard prophylaxis, and 4th month onwards he developed fatigue, stopped gaining weight, and in fact lost weight, which we don't see normally after transplant. He had good appetite. There are no GI symptoms as such. He was found to have progressive increase in creatinine from 5th month. Examination didn't reveal anything. There was no edema. He didn't have any lymphadenopathy, no organomegaly. Chest was clear. There were no neurological deficits. And sugars were continued to be high. He was on insulin. Chest X-ray was normal. Cultures were negative. Ultrasound did not reveal any hepatosplenomegaly. Otherwise, shrunken kidneys. Lab reports I will come to. Ultrasound, initially I was given normal, but later they updated saying ultrasound showed large size kidneys, 13 centimeter kidney. So the gist of it, 3rd month onwards he started having problems. One was very early onset of proteinuria, as seen in PCR 1.7. Creatinine had gone up from 0.8 to 1.2. Hemoglobin was normal, platelets were normal. There was no proteinuria as such, even they saw in the urine routine. In the 5th month, there was a significant jump in creatinine to 2.4. Albumin was normal. He had proteinuria of almost 2.8 grams. PCR was 6.4. Other labs, essentially CBC was normal, hemoglobin continued to be normal, platelets were 1.8 lakhs. Tacrolimus levels were acceptable for the ATG induction, it was around 7 to 6.5. DSA was negative. Only significant thing was large size kidney, 13.6, bulky with heterogeneous increased echoes in the graft kidney. This was all I was given. To summarize the case, it was a post-transplant graft dysfunction with proteinuria, onset being 3 months, graft dysfunction developing at 5th month. Native kidney disease is unknown, but had probably a proteinuric chronic kidney disease. What can we think of at this juncture? One is whether it is any de novo disease, but it is too early for a de novo disease to come within 3 months, whether we should think of a recurrence of FSGS like a malignant FSGS or an MPGN recurrence. Is it a plasma cell dyscrasia, less likely. Diabetic nephropathy recurrence and transplant glomerulopathy is too early for a 5th month to happen. You cannot rule out a rejection in any transplant patient that too early, 3 to 5 months. But compliance looks okay because his tacrolimus level was good. And should we entertain any viral infections like BKV, which we don't have the information. Data which could have helped us to rule out or rule in some things. If we had a native kidney disease, we could have thought of a recurrence. Anti-PLA2 antibodies, we don't have pre and post transplant as well. Serum BKV viral load, we don't know. CMV IgM was given, which was negative. Report was given to me. DNA is not available. Assessment of complements, will it help? Not sure, because platelets were okay. Hemoglobin was good, didn't fit in with any HUS or TMA. Serologies were provided later to me, they were all negative. Even HBV, DNA, HCV, RNA were negative. To summarize the case, it's a post-transplant graft dysfunction with proteinuria at 3 months. Graft dysfunction started at 5th month. Possibilities, as I mentioned, diabetic nephropathy, not possible, too early, small size kidneys. Recurrence of a glomerular disease or a de novo, possible. The most closest recurrence would be FSGS MPGN. Rejection doesn't look like a cellular, if at all it has to be an antibody mediated rejection, but odd points were 2.8 grams protein, which we don't see, normally less than 1 gram is the recommended cutoff. No DSA, so unlikely to be an AMR. Any other unusual causes for proteinuria recurrence like amyloid, fibrillary or paraproteinurias. Infection BKV has always to be kept in mind. So I looked at AI, which I think becoming more and more popular. I'm not sure how many of you are familiar. One of my junior colleagues told me Copilot is supposed to be very good in searching. So I was looking at what is the definition of recurrence. Recurrence of disease in kidney transplant is defined as reappearance of original kidney disease that led to end-stage renal disease. So to define as recurrence, we should have the original kidney disease biopsy. It could be either primary or secondary. They can range from various clinical and subclinical presentation. Time of onset defines what disease we are looking at, and a complete kidney biopsy is essential, including immunofluorescence and probably electron microscopy, to look at what is the cause of recurrence. So this is the big list of recurrence. I won't go into these details. Following transplant, recurrence or de novo is an important cause of allograft premature failure. All GNs can potentially recur. Most common are FSGS and MPGNs. By definition, according to clinical criteria, true recurrence, you should have both native and recurrent disease biopsies to define as a recurrence. If you don't have, you can define them as transplant glomerulopathy, occurrence of a new disease in the graft. De novo, if you have again occurrence of a new disease in the graft. Recurrent disease can be primary, as I mentioned, or secondary due to various systemic diseases, or it could be rarely a metabolic disease like oxalosis, Fabry's or any fibrillary. As I mentioned, true recurrence, you should have both native and transplanted kidney biopsy. Many of the times we see biopsy of the native kidney is not possible, and anyone coming with post-transplant deterioration of renal functions are most often misclassified as either chronic rejection, or if you don't do biopsy with what disease in mind, you may miss if you don't do immunofluorescence. So that's the importance of doing immunofluorescence in a transplanted kidney. Many times we may take a single core and brand them as transplant glomerulopathy and miss a recurrence. So if you look at recurrence predominantly, it could be either immune complex diseases or glomerular podocytopathy and glomerular diseases with organized deposits. Paraproteinemias are one of the significant causes of recurrence, especially light chain disease or proliferative PGN-MIDs. We should not forget vascular causes and inherited metabolic causes. There is a paper from Catran group from Toronto where they had looked at recurrences in protocol biopsy, where they had seen less than a year recurrence, which is our patient, that is 5th month. The most common cause was either an FSGS or an MPGN pattern. And it contributed to significant graft loss. The most common cause for graft loss in a recurrent disease is FSGS and MPGN, MPGN being the topmost. We had looked at our own data for 1.5 years. We had looked at almost 200 transplant biopsies who had both light microscopy and immunofluorescence. Immunofluorescence normally we don't take. These patients had all immunofluorescence done. Out of them, 71 patients had post-transplant glomerulopathy, and we had defined them as the standard recurrence, or if we don't know the native kidney disease, as unclassified, and significant proportion of them had both recurrence and transplant glomerulopathy. The majority of that was FSGS. If you look at again the time occurrence of recurrence, FSGS was the most frequent in less than 1 year. In any early transplant glomerulopathy, FSGS is probably the most common recurrence. This is another one more study where we looked at both. We had native and transplant kidney biopsies available, where the again most common cause was FSGS, and it was the earliest one to recur as early as less than few days. Coming back to our case, we look at time frame because this is a very early recurrence. This happened within 6 months. So statistically, if you look at it, it could be either FSGS. Sometimes if we do very early biopsy, you may see only minimal change like pattern, or it could be an early onset of MGN or C3GN and PGNMID, or a de novo. This is beyond 6 months. I won't go into details because our case is different. So coming back to our case, is it a de novo or a recurrence? Pointers for recurrence are early onset proteinuria, graft dysfunction less than 5 months with proteinuria. Native kidney disease, ideally if we had, it would have been the best, but again it was a proteinuric disease. He is a young male with rapid progression. By definition, more than 3 months is a late recurrence. What are the pointers against de novo? Very early onset, unlikely to be de novo. Usually de novo occurs much later, after 12 months. And he had a proteinuric native kidney disease, so probably we should think more of a recurrence. And graft dysfunction are happening so early, won't happen in de novo. This was again justified by paper from Catron, where they had seen de novo usually happens after 12 months. Within 12 months is more common a transplant recurrence. Recurrence of FSGS, all of us know it's a podocytopathy, and as I mentioned earlier, this was a protocol biopsy where they did very early biopsy. They didn't find anything in the light microscopy except for the food process effacement, which was seen in an electron microscopy. An Australian study where they had looked at 28 years of registry study from 1985 to 2013, where the again commonest cause and earliest one to recur is FSGS as early as 0.5 years. The next commonest one was MPGN, less than 2 years of recurrence. So these are all the risk factors. I am sure all of you know. I won't go into the details. So what does our case have in this risk factor? He is young, rapid progression to uremia, living donation, and low body mass index at transplant. This was corroborated by a Tongo project. I don't know if any of you are aware of this. This is a long project where they had looked at almost 10 years of transplant recipients, 11,000 transplants. They again showed that FSGS was the earliest one to recur, and people lost graft commonly because of FSGS. So as I mentioned, less than 3 months and more than 3 months are the cutoffs for early and late recurrence. So anytime you have an FSGS, don't forget to evaluate for secondary causes of FSGS if it is more than 3 months, especially infections like parvo, unusual infections, even COVID has been known to cause FSGS, and don't forget about the medications. So coming back to our case, what are the pointers for recurrence of FSGS. It was an early onset of proteinuria, less than, at 3 months he had proteinuria and had graft dysfunction at 5th month. Proteinuria was 2.8 grams. He was younger age. Rapid progression of native kidney disease, which was worsened probably by COVID, and very short duration of diabetes, hence diabetic nephropathy unlikely. What are the pointers against FSGS here? Late recurrence, always think of secondary cause, especially more than 3 months. Though he had proteinuria of 2.8 grams, it is not like a nephrotic. Physical examination didn't show any edema, so it is not like a nephrotic picture. And there was incongruity between urine PCR and 24-hour. Urine PCR was 6.8 and 24-hour protein was 2.8 grams. Native kidney biopsy, we don't know. Few words about IgA nephropathy, very unlikely, usually it recurs late. I won't talk much here. Recurrence of membranous again happens late. Here if we had PLA2, it would have helped. Usually the recurrence happens more than 13 to 15 months. And maximum recurrence is seen with PLA2, almost 80% if PLA2 is positive. Secondary GN, I have already said unlikely because of we don't have HUS like picture here. What is the second possibility? MPGN, earlier known as 1, 2, 3, now classified as immune complex or C3. I am sure all of you are aware about the newer classification, whether it is immune mediated MPGN or C3 glomulopathy. There can be some overlap sometimes. And as I showed in the previous paper, MPGN was the most common disease to recur in Catran's paper, where they saw it was statistically significant. And if you look at MPGN alone, what are the possibilities? Most common thing was either a monoclonal gammopathy or a C3GN. Here I think C3 was given, C3 was not available in this case. So immune mediated disease, MPGN with monoclonal deposits recur often, very early in the transplant. It often has an aggressive course. 70% of these cases you will not be able to demonstrate monoclonal immunoglobulins either in serum or in the urine. Although this disease, you can see deposits of IgG kappa. If you stain specifically, you may find, otherwise you may not find. And 30% of MPGN categories, you cannot demonstrate IgG in bone marrow. These are classified as MGRS. I am sure all of you are aware. The risk of recurrence in this type of disease is much, much higher. So this was again from Catran study, where they saw that when you biopsy at 3rd month, they didn't find anything, but kappa was positive. At 6th month, they are seeing complete lobular structure indicating MPGN recurrence. So if you do early biopsy, you may not find anything. I mentioned this. And the most common thing is either a complement disease or a monoclonal gammopathy, which is statistically significant in any of these studies. And half the patient lose their graft because of MPGN recurrence. This was again Australian study where they saw more FSGS and MPGN. To summarize our index case, this was a post-transplant graft dysfunction with proteinuria. Possibilities I have already mentioned, diabetic nephropathy unlikely, FSGS we have discussed, MPGN, rejection less likely because of heavy proteinuria and good TAC levels. BKV nephropathy is definitely a possibility. Few unusual pointers I would like to draw your attention here, where urine routine continued to be, there was no protein, but there was a PCR of 6.4. Calcium, if you monitor slowly, it went up from 8, 10, 10.9 to 12 by the time they saw at 5th month. Always had normal albumin. Statistically also, if you look at the rate of recurrence, FSGS is the earliest one to recur. The second most common one is something like a PGNMID or light chain disease. Even de novo, this FSGS and MPGN are most common. Coming back to MPGN pattern, If you do immunofluorescence, it will pick up. Here we don't have hepatitis B and C. Doesn't look like an autoimmune disease. Monoclonal gammopathy is something we need to think of. C3 doesn't look like C3 disease here because C3 was normal. This is a busy table, I won't go into. This was our experience in similar case where we had a recurrent de novo PGNMID. A lady presented with at 4th month, biopsy showed mesangial proliferation and immunofluorescence was positive for lambda light chain. Here again myeloma workup was completely negative and biopsy showed lambda light chain restriction. She was falling into MGRS category with PGNMID, needed bortezomib and other therapies. Very few handful of such cases are there in the literature. Points favoring MPGN in our case, a very early onset proteinuria, graft dysfunction, second most common disease to recur, very young age of recipient, normal albumin with no edema state in clinically, no much of albuminuria in urine routine, but you see PCR being 6, higher than normal calcium to be kept in mind. Magnesium is something which was always coming back to my mind, why he was persistently hypomagnesiemic, whether it is something like a tubulopathy, which is commonly seen with light chain disease. Since he had very good urine output, which is against ABMR. What are the pointers not in favor? Didn't see much of hematuria here, only 2 to 4. There are no complement levels available. Native kidney disease is not known. Information again, it should have been helped if we had like a native kidney disease biopsy, BKV which if it was available, and paraproteinemia workup if it was available, it would have probably helped us a lot. This is another our case where we had published about crystal histiocytosis, where we had seen plasma cells in the kidney. In the blood there was nothing. This gentleman presented during COVID with severe renal failure. We directed this, responded beautifully well, came off dialysis. This is our spectrum of MGRS published 6-year study, where the most common cause of MGRS was, one was AL amyloidosis, the second one was monoclonal immunoglobulin deposition disease. Rejection I have already spoken, not many pointers for rejection, though time frame fits in, nothing else fits for the rejection here, and proteinuria is probably against ABMR. Anybody presenting at 5th month, we have to talk about BKV, so only few words about BKV, I am not going to details. For few words about half month stain, half inch image for PGs, it has to be done with electron microscopy, supposed to be more specific. Decoy cells is given away, none of them do. You need to have viremia to prove that it is BKV infection. Viruria happens first and then viremia happens later. So clinical manifestation, all of you know there are 3 stages. Not many pointers for except the time frame. If we had a viral load, we would have definitely thought about. Having come to CPC, is it a simple BKV? Unlikely, they wouldn't have given a BKV for a CPC discussion. So this is my last slide. What is my take on this case? Probably a monoclonal gammopathy like pattern, whether it is a light chain disease or AL type of amyloidosis. What are the pointers favoring? Native kidney disease is some sort of a chronic tubulointerstitial like disease, never ever had hypertension even on dialysis, so which is probably against a GN. Persistent hypomagnesemia is bothering me. Non-nephrotic proteinuria, lot of incongruity between urine routine, that is urine protein, and PCR. A thickened interventricular septum in MPI scan probably indicates some sort of a deposit disease. Very, very non-specific symptoms like fatigue, unintentional weight loss are very common in diseases like monoclonal light chain disease or AL amyloid. MGRS like illness, higher than normal calcium, and again as I mentioned non-albuminuric proteinuria. If we want to connect native kidney disease and recurrence, probably light chain disease or LCPT, I don't know how many of you are aware, light chain proximal tubulopathy with recurrence, probably a non-GN disease is my take on this case. I leave it to the judges, and if I have time, I would like to ask audience, what do you feel? I'll give 3 choices. First choice BKV, any hands up? Second choice FSGS? Any hands? Anyone for MPGN pattern of monoclonal gammopathy? Thank you. More nephrologists are here. So the proof of pudding is to see and eat. So we need to hear always in our practice, pathologist has the last laugh, or probably we are more dependent on pathologists. Without their inputs, we will not be able to treat. So thank you, chairpersons, for your patience and your time. Anything judges wants to ask?
Thank you, Vishwanath. That was very detailed analysis. First of all, I think my co-panelists also will agree that it is a very difficult clinical scenario. You can't really pinpoint to a particular diagnosis. There are some clues for several possibilities. But certain points of interest before coming down to the narrowing down the possibilities of the actual diagnosis, there are certain things to ponder over. First thing is that the COVID pandemic and the kidney, we all of us have come across kind of exacerbation of previously existing chronic kidney disease on the one hand. On the other side, acute kidney injury occurring and rapidly progressing into CKD without any kind of remission. One such thing is a collapsing glomerulopathy, COVID-associated collapsing glomerulopathy, and that can result in kind of an ESRD status within few months and going up a contraction. And in spite of being a glomerular disease, it can just have a predominant